Chapter 12, Medical Considerations and Technical Rescue. The knowledge objectives. Give an overview of medical care priorities during technical rescue. Discuss the impact of medical technologies on technical rescue. Discuss the difference between non-medical and medical patients. Identify and describe medical assessments and interventions common in technical rescue. Discuss the prevention and treatment of suspension trauma. Describe how to integrate efforts and techniques to meet both the rescue and medical needs of a patient. Overview: medical care during technical rescue. This chapter provides a general outline to help the rescue team and medical provider develop an integrated approach to the medical care of the victim during helicopter and technical rescue. It is an introductory guide to the integration of the two critical arms of technical rescue. 1, the management of rescue systems, and 2, the management of medical care of the victim during technical rescue. Overview of medical care during technical rescue. 3 subject areas: medical pre-planning, medical equipment, medical skill level training and knowledge. And then more information on medical care of the rescue victim is available through organizations that provide specific training in rescue medicine and prolonged and delayed victim transportation, disaster medicine and wilderness medicine textbooks, and peer-reviewed journals. Overview: medical care during technical rescue. Medical care during technical rescue can be more challenging than urban pre-hospital EMS. Victim assessments and medical interventions must be adapted for use within the confines of technical rescue operations. 2 of the major constraints affecting medical care during technical rescue operations are the hazardous environments in which the rescue is performed and the technical equipment used for rescue. Overview: medical care during technical rescue. The delivery of medical care during rescue is made more challenging by hazardous settings such as electrical towers and structure fires. A balance must be achieved between the delivery of on-scene medical care and expedient evacuation or extrication. Rescuers must view each case independently and resist adopting a one-size-fits-all protocol-driven approach to medical care, victim packaging, and rescue rigging. The division of rescue team members into riggers and rescuers has reduced in recent years. A well-rounded technical rescuer should be as competent with technical systems as he or she is with medical care. 2 examples of integrating technical rescue systems and rescue medical processes are the avoidance of victim packaging methods that interfere with litter bridles, the avoidance of litter bridles that prevent easy access to the victim during high-angle operations. A growing list of medical guidelines has been developed for rescuers working in extended care settings. The unique conditions of technical rescue require that all aspects of the medical care be periodically evaluated for improvement. Always evaluate the risk versus the benefit of implementation of such devices or procedures. Patients in remote, hazardous, and vertical terrain often need skilled rescue and urgent medical care. Interventions that may be required during rescue include supervision of the patient's airway, oropharyngeal suction, initiation of IV or IO lines, initiation of more complicated procedures such as placement of an emergency airway device, direct laryngoscopy, or resuscitation. Medical pre-planning. Programs that assist in improving medical pre-planning should integrate medical and technical skills in all phases of the curriculum. Consider the impact on the other discipline when selecting the procuring rescue and patient care technologies. Medical pre-planning can help minimize problems by identifying conflicts in advance of their occurrence and adapting either the medical or the rescue system. Medical pre-plans depend on the availability and composition of personnel, equipment, and financial resources. Consequently, pre-plans vary among teams and agencies. Medical personnel. A common problem during high-angle rescue arises from the division of rescuers into either medical-focused or rescue system-focused personnel. Don't assume the most highly qualified medical personnel will always be present, able-bodied, and physically capable of reaching the patient for all rescues. Medical personnel. Medical personnel who are unable to deliver medical care because they lack technical rope movement skills are common. Widespread medical training ensures that search teams are able to provide initial care to a patient when found before advanced rescue providers can be brought in. Medical personnel. Medical personnel must maintain adequate physical condition and competency with personal technical skills to allow them to deliver medical care to the patient. Medical personnel who cannot ensure their own safety in technical rescue settings pose a liability to effective operations, and they diminish the efficiency of and increase risk for the entire rescue team. Medical personnel. Increasing the number of medically qualified team members improves the availability of skilled medical personnel. Number of medical personnel can be increased by publicly soliciting for interested medical care providers, providing incentives for team members to seek higher levels of medical training, rotating personnel into the role of litter tender or primary patient care provider, and challenging the team with a variety of medical or trauma problems during training exercises. Medical skill level and training. There is no universal standard for medical care during technical or helicopter rescue. There is an incredible variance in the skill level of medical care providers staffing technical rescue and helicopter rescue. The need for advanced medical procedures during technical rescue is actually low. Medical skill level and training. For most cases, medical care during technical evacuation remains basic and practical in application. However, there would be advantages to having advanced medical providers in the technical environment. Advanced medical providers have a larger medical skill set, they are more knowledgeable in their clinical decision-making ability, and can balance basic medical interventions with the need for advanced procedures or medications. The litter tender. The rescuer with the greatest responsibility for patient outcome is likely the litter tender. The most appropriately experienced medical personnel who are also qualified for litter operations should attend to critical patients. All rescuers who may care for the patient should practice medical procedures while on rope and under realistic conditions. Medical procedures should not be practiced during a technical emergency. The litter tender. Advanced levels of medical training do not necessarily result in improved medical care or outcomes. An experienced litter tender certified at the first responder level will have less difficulty managing both the litter and the patient compared to a paramedic who is inexperienced in the high-angle environment. Special cases. In exceptional circumstances, the patient may require both the most advanced medical care and the most proficient litter tender. Medical care and litter handling are likely to be improved by the addition of a second litter tender. Preparation and training. Rescue teams may encounter problems when they transport patients with particularly severe injuries or complex medical problems. Preparing in advance can be advantageous to both the rescue team and the patient. Preparation includes organization of team personnel, completion of the medical pre-planning steps, and integration of medical pre-planning steps into comprehensive, realistic training exercises. Physician medical direction and oversight. The majority of modern rescue teams find it essential to operate under some form of formal physician medical oversight. This includes both direct, either on-scene or online, and indirect, developing appropriate protocols, quality assurance training, and documentation, etc. Physician medical direction and oversight. Direct medical oversight may consist of on-scene care or supervision. Such supervision is usually provided by a qualified member of the rescue team, or supervision is remotely delivered through an online medical control. Most medical directors are physicians recruited by the team, many of whom are unfamiliar with the complexity and demands of technical rescue operations. Physician medical direction and oversight. Many teams have found it helpful to include conventional urban-based EMS physician medical directors in rescue training exercises. The team and medical control officer must ensure that an appropriate balance is maintained between the patient's medical needs and the rescue team's capabilities. Financial resources. Developing and operating within a training and equipment budget is a necessary skill for all rescue teams. A limited financial budget does not mean that quality medical care is also limited. Medical technologies. Until recently, medical technologies employed in technical rescue were adopted from other emergency medical care settings. However, the rising demand for small, portable, robust medical monitoring devices has prompted the development of rescue-viable technologies. Some simple pre-existing technologies can also be adapted to work nicely in the vertical world. For example, a heart rate monitor that transmits heart rate to a watch. Key attributes of technologies found to be helpful for patient care during rescue include simple, adaptable, and durable, small, light, and easy to handle, long battery life, valuable data and quality display or alarm settings, and reasonable cost with high return on investment. Regardless of the origin of medical equipment, the team must consider how and how often the equipment will be used for patient care. Key considerations are the durability of the equipment, the weight of the equipment, and the portability of the equipment. Minimal changes in standard technique may be all that is required to accomplish a medical treatment objective. Virtually all rescue teams have found it necessary to alter the rescue system to reduce interference with the care of the patient and change the manner in which medical care is provided to allow for certain technical rescue configurations. Medical technologies. Most fire service rescue teams will use a rescue medical kit that can be carried to a patient and used throughout the operation. These kits should be lightweight and as low profile as possible. Most alpine mountain rescue teams will take a modular approach to a medical kit. Individual items, bleeding control, IV start kit, splinting material, oxygen, etc., are divided among team members when hiking or assessing a patient. Benefits to the patient. Technical rescue is a treatment environment that imposes limitations on the ability to deliver medical care. Some teams may find it impossible to provide certain levels of patient care. The rescue team should critically review each piece of medical equipment to judge its benefit to the patient. The advantages of specific medical devices should be weighed against alternative methods of performing the task. Tragedies in patient care can be avoided if rescuers resist the loss of skill that occurs when care providers become dependent on medical equipment. It is unwise to rely on systems that lack redundancy or have functions that can be duplicated with manual skills. Weight and durability. The weight of medical equipment is critically important for teams that use helicopters or that manually transport equipment to staging sites at higher elevations. Weight is often reduced in spinal immobilization devices, stretchers, medical consumables, in particular oxygen delivery systems and IV fluids, and patient monitors. Most medical equipment used in rescue has been made more rugged in an attempt to increase durability. However, this process increases weight, bulk, and cost. Technical Rescue Medical Kit. A TMK is designed to work within the confines of a technical rescue system. The TMK should be used by the primary medical provider and/or litter tender. Some providers will choose to have a TMK as part of their litter setup, while others will choose to integrate this kit into the overall larger field medical kit. Technical Rescue Medical Kit. Under field conditions, the best TMK has the following characteristics. It is small and durable. It has a load-bearing tie-in at the top. It is top-loading and has few side zippers. It has internal fasteners for tying in equipment. It is easy to use while hanging in vertical situations, in the darkness, or in poor weather. It contains drugs and equipment appropriate for treating high-probability injuries. It is appropriate to the provider's level of certification. Technical Rescue Medical Kit. The TMK design and contents require careful pre-planning, preparation, and evaluation. For the first responder, basic trauma dressings, splints and/or tourniquets, oropharyngeal airways, suction devices. For the paramedic, a few appropriate injectable medications, an IVIO start kit, IV fluids, ultra-portable monitoring devices. Technical Rescue Medical Kit. The litter tender must also be competent in managing the technology or intervention and know what to do in the event of an emergency. In the case of an intubated patient, emergencies a litter tender may face while raising or lowering the patient are the patient's bag valve mask becomes disconnected. The patient expels the endotracheal tube. The patient's artificial airway becomes compromised or dislodged. Practical points for the Technical Rescue Medical Kit. The ideal TMK is streamlined to allow for easy carrying, handling, and access while suspended from the litter. Weight and volume limitations require that the TMK be adapted for each rescue. If there is equipment that is not needed and can be quickly removed, by all means remove said equipment. It will just be more of a weight and size burden. Medications for the technical rescue medical kit. The value of drug treatment during the rescue phase of patient evacuation is a subject of debate. Many teams include small quantities of all medications found in the large team medical kits. However, when medication use during rescue is retrospectively reviewed, it is evident that only a few medications are used with any frequency. Medications for the technical rescue medical kit. Points to consider. Pharmaceutical treatment should be initiated before the technical phases of the rescue whenever possible. The TMK should only include injectable medications. Medications that exert their effect over a period of hours are unlikely to produce measurable benefit when administered during the rescue unless the litter operation lasts several hours. The medications in the TMK should address the needs of high probability injuries. The number of drugs in the TMK should increase with the level of medical care provided. The drugs in the TMK must be inventoried and rotated to prevent degradation caused by prolonged storage or extremes of temperature. Each of the medications in the TMK should be partnered with a drug that will counter the side effects of therapy. Non-medical patients. A non-medical rescue involves a patient who is either not injured or who has a mild illness or trivial injuries that do not require urgent medical attention. During non-medical rescues, the rescuer need only ensure that the patient is transported safely, but must always be equipped and ready for the unsuspected medical event to occur. Medical trauma patients. Stabilizing medical care should not be delayed until the rope rescue has been completed. Common examples of rescues requiring medical treatment and monitoring during rope operations include raising unconscious patients from toxic environments, rescue of a utility linesman electrocuted while working on power lines, and lowering a climber with an extremity fracture or head trauma. Triage. When you are faced with multiple patients, use a standardized triage protocol to aid in medical rescue decision making. Assigning a triage priority to a patient will involve the following assessment questions. Is this a rescue or recovery? What are the available resource capabilities? What are the resource priorities? And what are the severities of patient injuries? Several triage assessment tools have been created in pre-hospital emergency medicine to aid the provider in making rapid decisions when faced with a multiple casualty emergency. Simple triage and rapid treatment triage is one such tool. START triage separates the injured into 4 groups: the expectant, who are unlikely to survive given the severity of injuries; the immediate, who can be helped by immediate interventions or transport; the delayed, who injuries are serious and life-threatening but who are not expected to deteriorate significantly over the next several hours; and the minor, who have minor injuries and are likely to deteriorate over the next few days. Triage. Setting priorities for evacuation and transport. Expectant patients are left where they are found and can be evacuated after all other triage patients have been evacuated. Immediate patients should be evacuated by the fastest means possible. Delayed patients can have evacuation delayed until all immediate patients have been transported, and minor patients are not evacuated until all immediate and delayed patients have been transported. Airway and breathing. Airway and breathing are primary concerns in all emergency medical cases. In a technical rescue, assessment and management of the airway and breathing are more complex than in other types of rescues. If the patient is unconscious, the airway must be under constant supervision to prevent occlusion that can occur secondary to improper positioning, deterioration of the patient's condition, or accumulation of body fluids. Airway and breathing. Current practice guidelines require that a medical attendant be with any patient at risk for airway or breathing difficulties. Any patient with spinal immobilization must have a litter tender available to intervene in case of an airway or breathing compromise. The majority of technical rescue patients will require a litter tender. Airway and breathing. Questions about the airway and breathing that should be addressed before packaging and moving the patient. Does the patient have a clear airway and normal mental status? Could the injuries or illness result in the onset of airway difficulties during technical rescue? Is the patient at risk of vomiting? How will the tender clear the airway during lowering or raising operations? Can respiration be monitored while the tender directs the litter over obstacles? Advanced life support. In addition to the basic interventions already mentioned, ALS airway and breathing interventions include maintain an open airway with an advanced airway. All intubations should be controlled. Control for emesis with advanced airway management if necessary. Circulation. The term circulation refers to adequate tissue perfusion with an intact vascular system, sufficient blood volume, and adequate cardiac output. The ability to control major internal or external hemorrhage in the rescue environment is limited. Patients with major hemodynamic instability from blood loss or other causes are an evacuation priority. Circulation. Treatments include prompt reduction of the rate of blood loss, prevention of hypothermia, allowing permissive hypotension by maintaining a systolic blood pressure of 80 to 90 using intravenous or intraosseous fluids when hemorrhage cannot be controlled. Patients must be continually assessed for the onset of shock. Signs of shock include altered mental status, increased pulse rate and respiratory rate, poor pulses in the extremities, mottled or discolored, cool and clammy skin, signifying poor capillary refill. Circulation. Questions that should be answered before packaging and moving the patient include, does the patient have a pulse? Can the pulse be accurately monitored during the rescue operation? Does the patient show signs of shock? What must be done immediately to treat for shock? What rescue procedures will increase or reduce the possibility of shock? Is control of hemorrhage effective? Is internal bleeding being missed? CPR for the trauma patient is generally not advised. The outcome from a traumatic arrest is incredibly low unless an immediate cause is found. Performing CPR in a technical environment is very challenging and can increase the risk to rescuers. Having medical protocols in place ahead of time or having the ability to access online medical direction can help in terminating these tough situations. Medications and technologies to aid circulation. In recent years, devices and medications have entered into the medical market to aid in the treatment of patients with blood loss, including topical hemostatic agents such as QuikClot or hemostatic gauze, such as Hemcon. The medication TXA, which is an antifibrinolytic that blocks the action of plasminogen, an enzyme that dissolves blood clots. Head and spine considerations. Spinal immobilization in austere and technical terrain can have significant ramifications on the path and equipment needed to extricate a patient. Asking your current rescue service medical director to review the guidelines can be a way of eliciting healthy conversation on such a controversial subject. It is beneficial in technical rescue operations to have a pre-existing protocol to rule out C-spine trauma. Head and spine considerations. Indications of spinal injury can include blunt trauma with a significant mechanism suspicious of spine trauma, a severely injured patient, altered mental status, or a GCS less than 15, or evidence of intoxication, neurologic deficits, thoracic or other significant distracting injury, and significant spine pain or tenderness. If any of these indicators are present, the patient will need spinal immobilization. Head and spine considerations. Rigid backboards traditionally used by ambulance personnel are very uncomfortable for long periods and can cause pressure ulcerations. A conforming backboard is the international standard for prolonged evacuation and technical rescue. Head and spine considerations. Head trauma should be considered in patients with alterations in consciousness, inadequate or chaotic respirations, skull fractures, bloody fluid from the ears, nostrils, or mouth, facial injury, head cuts, lacerations or bruises, amnesia, ataxia, and vertigo or dizziness. Head and spine considerations. Head trauma patients are prone to nausea, vomiting, altered mental status, other critical injuries, hypertension, bradycardia, and shock if profuse bleeding from the head is left untreated. In the presence of suspected head trauma, the medical provider should assess for the presence of Cushing's reflex. Cushing's reflex presents with increased blood pressure, irregular respirations, and a reduction in heart rate, indicating an increase in intracranial pressure, or ICP. Head and spine considerations. Questions about the status of the head and spine that should be answered before packaging and moving the patient are: is there a possibility of a head or spinal injury? Should spinal precautions be performed before the patient is moved? Should the patient be secured to a spinal immobilization device before being immobilized in a litter? Can the litter tender support the patient's breathing and circulation during evacuation if needed? Will immobilizing the patient dramatically increase the overall rescue risk to the patient or rescuers? Head and spine considerations. For the head trauma patient with suspected increased ICP, positioning the patient in an elevated head-up position or in reverse Trendelenburg is most beneficial. Head trauma patients also may benefit from administration of an antiemetic due to potential nausea or vomiting. In recent years, a number of new situations and new mechanisms of injury have been described for patients treated by technical rescue teams. A number of syndromes have also been implicated among rescuers and rope access technicians as well. The most publicized and controversial medical issue in modern technical rescue is suspension trauma, also known as harness hang syndrome, harness syncope, or suspension syndrome. Suspension trauma in technical rescue. It is known that people have become unconscious from hanging in a harness. Once syncope occurs, death can occur if correct action is not taken by lowering the person to the ground. Research on this syndrome is ongoing. There could be a number of neurologic, vascular, and metabolic events associated with prolonged suspension in a seat harness. Interviews with victims of harness syncope have been unrevealing. Pre-syncope symptoms widely vary. Severity of symptoms does not correlate with the time of syncope or the severity of post-syncope events. At this time, the medical protocols for managing suspension trauma are focused on preventing additional stress to the patient. Prevention. Leg loops and shoulder loops have been casually associated with syncope. Guidelines suggested for preventing suspension trauma are: avoid sitting with legs motionless. All rope users should practice self-righting and harness unloading. Harnesses should have flat, wide webbing leg loops and be correctly adjusted. Safety personnel should supervise all static hang training operations. Training sessions should be supported by rapid lowering capabilities to allow quick access to the patients. Treatment. All patients who develop lightheadedness, nausea, vomiting, or vertigo, or changes in mental status should be lowered to the ground immediately to restore unimpeded blood flow to the heart. The priority in these cases is to restore unimpeded blood flow to the heart by reducing compression on the thigh, lower abdomen, and head and neck regions. The current body of evidence and clinical experience with the resuscitation of suspension trauma patients supports several treatment recommendations. Treatment. The harness should be quickly removed. Pulses should be checked and character noted. If an EKG is available, it should be used to record any dysrhythmias. The patient should be placed on oxygen. If IV access is possible, consider giving a fluid bolus if indicated by a decreased blood pressure. Vital signs should be reassessed at 5-minute intervals if possible. A detailed history of events should be obtained from witnesses. Rescue and medicine, putting it together. Care must be taken to protect patients from injury during rope rescue. Not all injuries require treatment before rescue. Seemingly stable patients can deteriorate, suffer from exposure, or receive additional injuries. ALS care can conflict with technical rescue systems and may also delay completion of the rescue. Rescue and medicine, putting it together. Advanced medical procedures are difficult to perform while suspended from a rescue litter and should be done before rope rescue or helicopter short-haul operations are begun if possible. Well-performed basic medical care is safer and more effective than improperly performed advanced medical care. The rope rescuer should anticipate and prepare in advance for medical problems that may arise during rescue operations. So in summary, medical care during technical rescue can be more challenging than urban pre-hospital EMS. Medical pre-planning can help minimize problems by identifying conflicts in advance of their occurrence and adapting either the medical or the rescue system accordingly. Any medical intervention introduced into the rescue systems must fall within the established skill sets and competencies of the litter handler who attends to the patient, rather than a more highly trained team member who is not attending to the patient. Basic medical skills are more easily adapted to changing rescue situations than are advanced medical skills. Preparation includes organization of team personnel, completion of medical pre-planning steps, and integration of these steps into comprehensive, realistic training exercises. The Technical Rescue Medical Kit, or TMK, is designed to be light, portable, and easily accessible to provide medical resources for the duration of a technical operation. A rescue in which medical care is required poses a markedly different challenge to the rescue team because stabilizing medical care should not be delayed until the rope rescue has been completed. A medical attendant must stay with any patient at risk for airway or breathing difficulties with any patient with spinal immobilization. The ability to control major internal or external hemorrhage in the rescue environment is limited. Therefore, patients with major hemorrhage are an evacuation priority.